It's my pleasure to have a talk today with Professor Luigi Camporota, who is from London and, of course, well known in the field of respiratory failure and ECMO in particular. He is, by the way, the director of the ECMO program at St. Thomas Hospital in London. We are both at the Mayo Clinic. That's the reason why Luigi has a tie. As in this institution, you need to have a tie. I don't. But we are here at a meeting on mechanical ventilation. And so it's the right time to have this discussion. Hello, Luigi.
Good morning, and thank you so much for having me this morning. I'm really delighted to be able to chat to you today, and yeah,
you are too kind.
Questions, yes.
You are too kind. So each of us is in his hotel room here very early in the morning today. But let's be serious and let's speak about what we learned from pandemics, and is the use of ECMO different now than it was before the pandemics? But before that, I will ask you, during the pandemics, there was an evolution, but how could we characterize it from the very beginning until the end, which is now? It's the end of the pandemics, isn't it? So what about the changes perhaps in patient populations, the changes in strategies, in organization? Let's focus on COVID-19 from the beginning until the end.
Absolutely. I mean, with the ECMO during COVID-19, I mean, we faced two challenges. One was that COVID-19 was a new disease. So the question is, we didn't know what the prognosis was, whether there was a different treatment. The prognosis was unclear. The first reports were not very encouraging, and then obviously very resource intensive. And the other side of the pandemic was clearly the large number of patients came through the service, which strained the capacity, the organization, the resources. They gave us the opportunity to think about triage of patients. And as you remember at the beginning, there was this idea, who should be considered for ECMO?
Yeah, absolutely.
And there was the idea that clearly patients in single organ failure with clearly reversible conditions were the ones that are more likely to succeed and therefore considered for ECMO. And that was mainly because the first indication, you remember the first reports, there were 80%, 90% mortality, and therefore there was a framework. The WHO gave some ideas, and the ELSO guideline essentially considered not only patients but also the resources of the ECMO centers as indication.
And how did it evolve?
What evolved is that the first data actually were very positive, in a way that the survival that was reported by the ELSO at 60 days was 31% mortality, which was very similar to the pre-COVID-19 outcome. And in the UK, for example, we had about 75% survival, which was exactly the same survival that we had in the pre-pandemic period.
Okay.
So we published data for the entire UK service. And
so that was encouraging. Yeah.
It was very encouraging. And so in a way, the limitation was mainly due to capacity, the strain.
Sure. Yeah.
But in terms of indication, we're not too dissimilar from the initial data, which was very interesting. Yes.
Okay. Yeah. And so, yeah, okay. And so if we compare ECMO now versus ECMO prior to COVID-19, could we see some differences, or is it about the same?
I think the main differences are that essentially we've learned a lot about how the length of stay of these patients. So if we think about the three waves, particularly, the first wave was very similar duration of ECMO, similar to the H1N1 and all the viral pneumonia. But the treatment changed, the steroids, the IL-6 inhibitors, maybe the greater use of non-invasive ventilation, later intubation. So what we found now in the third wave, particularly, is the length of stay is quite prolonged. And then clearly that has got an effect on capacity, on organization, and also outcome. We have data from the EuroELSO, for example, from the EuroECMO survey, that the length of stay is increasing and the time of disease to wind ratio is also increasing.
Luigi, we are pressed by time here.
Yes.
In the UK, you have centralization of ECMO. Is it a good thing for you?
I think we found it very helpful because we know that, for example, we can centralize the volume outcome relationship is very important. The governance is very important. And essentially we can learn from each other. And also the volume itself improves outcome, we believe.
But if indeed the number of ECMO facilities is limited, don't you think that we could have increased or extended the use of ECMO to smaller institutions that could gain experience themselves?
I think in a way we did that. We had some surge centers, we called, so some centers that were not doing ECMO before. But what we've learned also from the French data is that centers that started during the pandemic had slightly worse outcome compared to so 3 times the odds ratio was. So but in a way,
but in the future, if we have easy to use machines, smaller machines, do you think the use could be generalized to all or virtually all institutions?
I think certainly it can be enlarged, and but I think I would keep the organization quite tightly governed, because the indication needs to be similar. I think is the equity of access, the equity of access to ECMO centers, and it's fair that the outcome would be comparable. So I think the number could be increased. Certainly the centers could be increased, but I think the organization is central to the outcome, I think.
Yeah, right. Now, perhaps the use of telemedicine will help us to help those in smaller institutions, don't you think?
I think it would be a great thing, the ability to interact with the team over there, seeing the ventilator, seeing the patient, being able to contribute a little bit more, not hands-on, but eyes-on would be very helpful. Yes.
Right. Yes. Now, I was impressed by the case report from Alain Combe and collaborators showing that in COVID-19, one patient could be treated with ECMO without any endotracheal intubation. Do you think that could be the future, to avoid endotracheal intubation in some cases, thanks to ECMO?
We have done quite a few awake ECMO, so non-intubated ECMO, but I think case selection is essential, because most of these patients might be suffering from high respiratory drive, and sometimes these patients might not be easily corrected by just gas exchange and ECMO. But the case reports from the American group that use Protec and awake ECMO seems to be very encouraging in the first wave, although I'm not aware that has been replicated since, but it's something certainly which would avoid delirium, the neurocognitive problems that these patients have. So it's something to be explored in a very sort of controlled, with clear indications.
Thank you very, very much. I think that was a very good discussion. You are explaining it so well. So I'll see you in a moment in the conference room.
Thank you very much.
Thank you very much, my friend.
Later on. Bye, everybody. Thank you.
Take care. Bye-bye.
Bye.